Good morning, everyone. Welcome to the 20-something Taste for the Cure. We started doing these, I think around our 28th year of doing Taste for the Cure. Anyway, it's so great to see everybody here. So happy to have all our interns and programs and projects represented for, this is just a taste. That's why we call it a Taste for the Cure. It's just a taste of all the great things that are going on at the Breast Care Center. And we are actually so happy to have our survivors and thrivers, the people who are in treatment. And this is just an opportunity for you to hear a little bit from some of our experts. We try and feature new people every year, but so you can learn a little bit about what's going on and ask some questions. Now, I want to remind people that when you're asking questions, please don't stand up and talk about your personal situation, because we're not equipped to be able to do that. That's something we do in consultation in the clinic, but we are happy to answer any questions in general for you to ask about our philosophies of treatment or things that you've heard that you're confused about. We never suffer from lack of questions. That is for sure. The one thing is this my phone? Just making sure I have a timer. And I do. Okay, perfect. So we are starting just a few minutes late, but we are going to get started this morning. So we've got a lot of fun things in store for you. We have our panel this morning about what's new in treatment, and I think you'll be excited to hear about all the new things that we're doing. We also have our Taste of Science today. Our own Kim Badal is going to talk about the work she's doing to try and look at environmental contributors to cancer. This is something that I know is of great interest to the community. It's been hard to piece this out. There have been many negative studies. We know that there are environmental issues that are involved in lymphoma and some of the blood cancers, and some cancers, of course, lung cancer and smoking. And so are there better ways for us to go about looking for that? And then one of the things that we want to say, too, is if it comes up, I might talk a little bit about screening and risk assessment. I want to say some of the most exciting news is that we are going to present the results of Wisdom 1.0 at the end of the year, and it will be published, hopefully, at the same time in New England Journal of Medicine. And this is something that we have talked about for a long time. You've heard me for decades say more is not better. Sometimes more is just more, and sometimes more is worse. But what is better is more personalized, more focused on biology, more focused on response, more focused on the way to learn. And guess what? That is true for screening. And that is a really big deal. We'll see those results. They'll be talked about a lot. I hope it will be practice changing. But I think we can identify the people at highest risk. I think we can do more for the people at highest risk to really reduce the chance of finding late-stage cancers. And more importantly, the reason you want to do risk assessment is to think about prevention. We want to make prevention a thing. We want to make it a thriving field. That's one of the reasons we have our new meeting, Rise Up for Breast Cancer, Step Up. It's Rise Up. It stands for Revolutionizing Investigations to Step Up Prevention for Breast Cancer, and that is February 19th to 21st. It's open to the public as well as all of our academics. It will be downtown at the Nico Hotel, and it was really last year was our first year. It was super fun, and lots of our faculty will be involved. But that's really, I think, the theme of today. It's been the theme of our entire Breast Care Center for as long as I've been here. Probably no accident. But I think that really we want to get to a point where we can tailor treatment to biology, to patient preference, and to our own performance, and to have that be a continuous learning loop. That's our goal for the Breast Care Center. And so, we are so excited to see so many of you here thriving. We are actually working hard to try and figure out how to make your treatments, less toxic. And you're going to hear a little bit more about that, and more effective. So for our first panel, we're going to get started With no ado, we'll take about 20 minutes to talk amongst ourselves and then open it up for questions. Joe Chen, who is the Director of Breast Medical Oncology here, is going to start over here on the left, all the way over here. And then next, Rita Mukhtar, who is leading the charge on lobular breast cancer, among many others, a rising breast surgery researcher. Then we have Dr. Nicholas Prionis. And can we get one more chair? Need one more of these chairs. And then we have Nicholas is our radiation oncology expert par excellence. And then, oh no, I think we have enough. Actually, we're good. No, just come right up right on here. And then we're going to be cozy. We're cozy. And then one of the newest members, we have two new members of our team, one young, one slightly more mature. Slightly more mature. Not much, but slightly more mature. Jordan Jackson just joined our faculty and is helping us lead the charge in the recast DCIS trial. You'll hear a little bit more about that. And after a, 5-year effort, we have been successful at recruiting Sandy Borowski, our long-term collaborator from UC Davis, pathologist par excellence and iconoclast, and redefining. You're over here, Jordan, and Sandy, you're here. Oh yeah, that's me. All right, so okay. Anyway, so we're going to get started, and there's going to be one set of mics on either side. Give everybody a big round of applause. All right, so I want to start with Joe, and I want to start, Joe, by just maybe giving us a taste of, since we are, of course, Taste for the Cure, we would like a taste of what are the kinds of trials that we are designing. How are we changing the way we're doing trials in the metastatic setting? And more importantly, how are we trying to bring some of this innovation up front so we can prevent metastatic disease?
Hello, everybody. It's really great to be here. So this is a big topic. I guess I'll first say the general way drugs are developed, they usually start in the metastatic setting, oftentimes later line, after patients have had multiple prior lines. And once you show that there's activity in that late line, we want to bring that up earlier into the metastatic setting, first line. The general principle is if you can get the best drugs early, outcomes will be best in the long run. And then once we can show that in the metastatic setting, these drugs are very effective, potentially even in the first line setting, then we start testing them in the early stage setting. That's the setting where we can cure patients. So we want to bring the best drugs early to cure patients that will prevent metastatic disease. And so there's innovative trials that span this entire spectrum. I'll start in the metastatic setting. One of the big abstracts that was presented at ASCO this year was around using circulating tumor DNA. And this is novel. The technology has been around for decades, actually, but our ability to use it in the clinic is still limited. It's not ready for prime time. But what we are doing is looking for mutations in that circulating tumor DNA that can predict whether a patient has stopped responding to their treatment, and perhaps we should change therapy. Historically, we rely on CAT scans, right, to tell us that the drugs aren't working anymore. But is there a way that we can use biomarkers earlier, before we see changes on a CAT scan, and switch therapy before we see that progression on a CT scan? It's controversial because we ultimately want to see that if we change treatment early, patients still live longer. We don't want to just move the treatments up early, but then run out of treatments in the end. And so this is why we don't quite know if this is the right approach, but this is where I think the field is moving, using biomarkers to assess response so that you can make treatment changes sooner and hopefully improve long-term outcomes. So if we extrapolate that and move into the early stage setting, right, we want to test these drugs early, hopefully cure more patients, but we want to know whether they're effective for you, for the specific patient, as early as possible. So many of you have probably heard of I-SPY, which is a trial looking at agents, drugs in the neoadjuvant setting where we treat before surgery. It gives us an opportunity to see how the tumor responds, how the patient's individual tumor responds. And we know if the tumor goes away completely with a course of chemotherapy or immunotherapy or whatever agent that we think is most appropriate for that tumor biology, we know that the patient's risk of recurrence will be much lower than if there's still residual tumor there or if there's very little change. And so what I-SPY is doing is we are first profiling the tumor, and then we are using a number of biomarkers to assess response while the tumor is still in the patient, and that gives us real-time information. And we've now, there's a new phase of the trial called I-SPY 2.2, where we are able to switch treatment if we believe that the tumor is not responding as well as we would like. And this gives patients multiple chances with multiple novel agents to hopefully have a complete response and higher chance of cure. So it's UCSF is the lead site. Dr. Esserman is the overall study chair. And I think this is the wave of the future where we need to identify who's responding and who's not responding, and testing drugs that we think are most effective for that tumor biology. It used to be one size fits all. Is the patient young or old? Is there nodes involved or not involved? But now it's much more, we are much more informed about the biology, who needs immunotherapy, who should just get endocrine therapy.
Yeah, who's getting that?
So in I-SPY right now, patients who are estrogen receptor tumors that are ER positive or PR positive, patients whose biology does not respond well to chemo. There are a number of tests developed to help predict which tumors respond well to chemo and which do not. So tests like MammaPrint or Oncotype. So part of our trial is we profile these tumors using these assays and select the ones that are MammaPrint low, we think do not respond well to chemotherapy. And so we give patients a trial of endocrine therapy and we monitor closely. And we look at whether the tumor has stopped proliferating, whether on MRI we're seeing shrinkage, whether the background enhancement of the normal breast decreases because the background is also responsive to anti-estrogen therapy.
Fantastic. So, Joe, Rita, I want to ask you. So, one of the things you're interested in is lobular cancer, and is lobular cancer need its own treatment, or do some of these things about profiling, still apply? So, fast-growing still is maybe a predictor of chemo, and slow maybe not. Tell us a little bit about lobular cancer, how varied it is, and kind of your hopes for how we might address this particular type of tumor.
Yeah, thank you. So there are two main types of breast cancer. If you look at the way that the tumors grow under the microscope when the pathologist is making the diagnosis, they're either going to say that it's invasive ductal cancer or invasive lobular cancer. Invasive ductal is more common. It's about 80% of all breast cancer, but invasive lobular is 10 to 15%. So the second most common type of breast cancer when you classify it based on the growth pattern. And we used to really think that lobular breast cancer was not different than ductal breast cancer. But more and more, we are realizing that although there are some similarities, there's also important differences in the growth pattern, in some of the proteins and genes that are expressed or not expressed between the two different tumors. Lobular breast cancers tend to grow in a more spread out pattern, so the tumor cells grow in single file lines, and that can be harder to see on imaging tests. So oftentimes, mammograms won't find lobular breast cancers until they're much larger. And I think that that's part of why we need people to do risk assessment. So Dr. Esserman talked about the WISDOM trial. So there are some people who might be better served with breast MRIs instead of mammograms, or in addition to mammograms, I should say. And MRIs are more likely to find a lobular breast cancer, especially if a person has very dense breast tissue. So getting that risk assessment to understand what kind of screening is best for a particular patient might help us diagnose lobular cancers a little bit better. And if we could have a predictor for who's at risk for lobular versus ductal, that would be even better, and that's work that is ongoing. Now, in terms of determining what kind of treatment is best for lobular breast cancer, there are tools that work for both ductal and lobular cancer. So for example, in the I-SPY trial, Dr. Chen mentioned this test called MammaPrint, which looks at the genes that are expressed by the tumor. So most patients who have lobular breast cancers, their tumors appear to be slow growing, and maybe you would think chemotherapy wouldn't be effective. And this is a big unanswered question for people who have lobular breast cancer. But in the I-SPY trial, people who have lobular tumors that are high risk based on this MammaPrint test, especially if it's the highest level of risk, actually have very good outcomes with chemotherapy in terms of getting rid of tumor in the lymph nodes. So if they start out with tumor in the lymph nodes, then you can give chemotherapy if the tumor has this very high risk gene signature based on the MammaPrint test. And a lot of those patients, actually, their lymph nodes will become normal. On the other hand, many patients with lobular tumors, the tumor is going to be MammaPrint low risk. And for those patients, we're actually putting them into the arm of the I-SPY trial that's not using chemotherapy, but instead using these hormone-based medications and trying to see if we can better tailor their treatment. So what I hope is that we will have more lobular-specific trials. There is a burgeoning interest and growth in interest in lobular breast cancer. As a matter of fact, this Wednesday, October 15th, is Global Lobular Breast Cancer Awareness Day. It's the second one. And we're going to be celebrating this with a special breast oncology program seminar on Wednesday morning, and then a Bay Area Breast Cancer Forum focused on lobular breast cancer Wednesday evening. Our program here at UCSF is actually hosting an international symposium on lobular breast cancer in September 2026. So if you want more information about either of those two events, please come and find me.
Okay, I'm going to ask Nicholas a question. I'm going to come back to you about axillary nodes. So, Nicholas, we tend to think about radiation as, okay, you finish your surgery. If you have breast conservation, that means you have to have radiation. Is that true, number one? And how have techniques changed, really? Not everywhere, but here and like in certain places in Europe.
So, as I tell every patient I meet, every trainee I work with, the most important decision is, do we do treatment or not? The best way to avoid the side effects of treatment are to not have to do the treatment. And so the biggest advancements we make are really around knowing who's really going to benefit and who can we forego the treatment. And so we're growing our knowledge base in that regard. We have really good data about women 65 years or older who have very favorable disease where we can potentially forego radiation. But kind of along the theme of giving chemo or systemic therapy before surgery and getting personalized information for that individual and their cancer, that's opening up this whole new world of being able to try to de-escalate treatment based on how they specifically respond. So about a year ago, a big clinical trial was published. We have the published data now showing that in women who have cancer, breast cancer known to be in the lymph nodes, not a large amount, but a small amount in the lymph nodes, who achieve a complete response in the lymph nodes at least, we're able to de-escalate treatment and not treat the lymph nodes. What's really powerful about that is that in that clinical trial, women who had a mastectomy then were actually randomized between radiation after mastectomy versus no radiation at all. And again, no difference, no benefit from radiation in those very carefully selected women. So that's a huge paradigm shift to now potentially be able to forego the treatment and the risks of that treatment in very carefully selected women. There are forthcoming clinical trials along this theme, HER2 positive breast cancer that's confined to the breast. If a woman achieves a complete response, we're looking at foregoing radiation entirely after lumpectomy. So no radiation and still conserving the breast. That's not published or presented yet, but forthcoming areas of study. So that's the most important change, is knowing where we can forego the treatment. Then, of course, we have all sorts of bells and whistles and ways we can make our treatments better. We are continuously getting shorter and shorter treatment courses. We just had our big annual conference hosted by Chance here in San Francisco a week ago, and there's more and more data about going down to 5-day, 1-week-long regimens, even treating not just the breast, but the lymph node areas as well. There's caution about worrying about nerves that are in that area, but there's growing bodies of data saying it might be safe. So down the pipeline, we're going to see more and more short treatment courses. Also, a large growing body of literature and evidence around the use of new types of radiation, like proton radiation. You can talk to me afterwards about what that means, but the principle is that it could maybe spare organs in the chest, like the heart and lung, better. So we're starting to study that and see more data coming out. UCSF is building a proton center coming in 2029, 2030, so a little bit further down the horizon. And then I think the big area that we're really moving towards on a shorter horizon is using more genomic information to, again, figure out who really benefits from treatment or not. In DCIS, there are well-established tests that I'll defer to Dr. Jackson to talk about. But in the invasive cancers, early stage invasive cancers, we are seeing tests coming down the line that are going to help us to really narrow down whose cancers are sensitive to radiation, whose cancers are resistant to radiation. And there are many clinical trials being designed using that genomic information to escalate or de-escalate radiation. So a lot to come in that domain soon.
So one other trial that's starting here is the prospective trial. This is Bruce Mann's work from Australia, and their observation was saying, well, maybe what radiation's best at is multifocal disease. So if you have, a relatively easy to read MRI and a solitary lesion under 2 centimeters, maybe you don't need radiation. And their results published from their single center were like 2%, 1 or 2%, I think, of people had a recurrence. What do you think of that theory?
Yeah, 2 schools of thought around recurrence. Is it that we're not seeing disease, and if we look harder with more scans and then ensure there wasn't a second site, surgically remove everything, then we'll do better? Versus, is it really biology and disease that is below the threshold of a scan that is leading to recurrence? It's a debate. But in this study, they're taking the former hypothesis and indeed are showing very, very low rates of recurrence, 1% at 5 years with just pills only, no radiation.
Oops, we're talking too long. Okay, sorry.
The key there is you got to be able to see the disease. So, are lobulars really going to be as
They included lobular.
They did.
20% were lobular.
They-
Just letting you
20%.
know. Just letting you know.
So-
Our minds are open, right?
Yeah,
We're letting
exactly.
the data teach us. Yeah.
So definitely, it's going to be a combined solution of really knowing the extent of the disease before you're starting treatment, really understanding the biology of the disease, and also now the sensitivity to different treatments.
So it's interesting. I think the surgeons have been. I think the surgeons come in 2 flavors. One is if it was good enough for Halsted, the Halsted radical mastectomy. If it was good enough for Halsted, it's good enough for me. And then the people are really pushing the envelope. That would be us here at UCSF. But of really trying to lead the effort in de-escalation, including maybe even omitting axillary surgery. And, Rita, you've done some work in thinking about even after a bad cancer, who can you omit? Is it possible to omit at least a full axillary dissection where, especially if you're going to combine radiation and full axillary dissection, you're looking at arm swelling, lymphedema, truly at this moment untreatable rates of 40%. And even if you do the special lymphatic things, it's 15%. But if you don't do it at all, it's 5%. So what's the thinking there?
So just like with the systemic therapies, where it used to be kind of one size fits all, everybody sort of gets the same kind of treatment. It really used to be the same way with surgery, where everybody would have a large number of lymph nodes removed from the armpit area, what's called axillary dissection. And as Dr. Esterman mentioned, doing that operation has a very high risk of causing swelling in the arm, which is known as lymphedema, which can be a permanent condition. So there have been a number of clinical trials over the last couple of decades helping us to right-size or tailor the amount of axillary surgery that we do. And there are really 2 reasons that people do axillary surgery. One is there is this need to understand the stage of the tumor, so how far has the tumor spread, to help make decisions about what kind of medical therapy the medical oncologist is going to give. And the second reason is to prevent tumor from growing in the axillary lymph nodes and causing what's called a local regional recurrence. And that tumor could cause problems locally with the blood vessels and the nerves in that area if it's not controlled. But now we actually have different ways of addressing those problems. So for the first issue of deciding what kind of medication the medical oncologist is going to give, more and more they're relying on the tumor biology and looking at these genomic assays like mammoprint and oncotype and other indicators of whether or not the tumor is going to respond to chemotherapy or what kind of treatment it needs. So we're relying less and less on just the number of lymph nodes that are involved to make those kind of decisions. So we don't necessarily need to take out so many lymph nodes for that purpose. And then in terms of preventing tumor from growing in the armpit area, we are more and more relying on our radiation oncologists. So radiation can often control the tumor in the lymph nodes, especially if it's a very, very tiny amount of tumor. So what we've really seen is moving away from just a blanket recommendation to remove all those lymph nodes. Many people can have just a sampling of the lymph nodes, so sentinel lymph node biopsy, where we're just taking out a few. There is also what's called tailored axillary surgery, where we're just taking out the lymph nodes that seem abnormal based on what we find during surgery when we're examining the lymph nodes or based on imaging. And as our imaging studies get better and better, we're able to find more of these abnormal lymph nodes before we even go to the operating room. What's exciting is that we used to think that if someone had cancer in the lymph nodes, we were going to have to take out the majority of the nodes. But if a person gets systemic therapy or neoadjuvant therapy before surgery, and we're able to shrink that tumor, we actually can avoid taking out the majority of the lymph nodes and instead, again, rely upon radiation. And just in the last couple of years,
Or as Nicholas says, if everything's clear, maybe
Or
not
not do
even
radiation at all,
doing
exactly.
anything.
If
That's
it completely
another reason
clears.
to do the treatment up front, right?
right. And then in the last couple of years, we've had 2 major clinical trials looking at people who are diagnosed at early stages before there's any indication that there's any lymph node involvement. So for people who have tumors that biologically seem not aggressive, not fast growing, small tumors, and especially probably maybe more in a postmenopausal population, but this has to be tailored to the individual patient. There are people in whom we don't even need to do any lymph node surgery at all, so not even a sentinel lymph node biopsy. So I think that we are really working hard to test this hypothesis that, or to find ways to not do surgery that could harm people, especially if we have other ways to get that information and other less toxic ways to address tumor that might be in those lymph nodes.
And of course, it's great to do new things, but the best way to do new things is to generate the data that helps many others to do less or to do what's more appropriate. And speaking of that, we're going to move to one of my favorite topics, which is ductal carcinoma in situ. So Jordan, let's kind of go over what exactly is ductal carcinoma in situ, and maybe you can talk a little bit about the RECAST trial and how we're trying to, recast DCIS as something perhaps as an opportunity for prevention.
Absolutely. Is mine on?
Yeah.
Okay, great.
Can everyone in the back
Perfect.
hear Jordan?
Fantastic.
Okay.
So as Rita started to already explain the 2 different types of cancer for ductal and lobular, DCIS, or ductal carcinoma in situ, is sort of a precursor or pre-cancer, and some people say, to the invasive ductal carcinoma. So in the breast, the ducts themselves are these round structures that you see under the microscope. They're lined with cells. When those cells themselves start to become abnormal and appear as cancer, but are confined or stay within the duct themselves, it's what we call ductal carcinoma in situ, or DCIS. So this is a stage 0. It's really a precursor to what we think invasive ductal carcinoma over time. The treatment standard of care, I'll start there, Laura, has been to treat this effectively as if it's invasive ductal carcinoma, with the goal of preventing it from becoming that, with a bundle of a combination of surgery, radiation, and endocrine therapy, or the hormonal therapy pill. The one new thing I guess I'll throw in for the radiation aspect for DCIS, there is one of these tests, as Rita was talking about, like mammoprint and oncotype for invasive cancer. There is a similar for DCIS called Decision RT, which evaluates the risk of recurrence for DCIS, both coming back as DCIS or invasive cancer, and breaks it down for us, giving us a risk depending on if you have surgery alone or surgery plus radiation. So one of the ways, if we're going with the standard of care to try to de-escalate or decrease the amount of therapy needed, it can help us decide based on your specific DCIS cells if radiation is added to that, if it will decrease your risk of it coming back. So one way for us to sometimes be able to safely omit or not give radiation for patients who have had the standard of care treatment for DCIS.
So Jordan, and that's an improvement for sure. But if DCIS isn't really a cancer, why are we starting with kind of the stage 1 cancer treatments? Is that necessary for everyone?
It's a very good question and something we've all been sort of asking ourselves for a long time, and what the RECAST study was sort of came out of that idea or that concept of wondering, are we doing too much for something that isn't invasive cancer and we're trying to prevent it from becoming that? So the RECAST trial is a clinical trial that we have here at UCSF and then many other sites in the country as well, but we are lucky to be one of them here. The trial is similar to what other people have talked about in treating the cancer before we do surgery, is similar in that we're treating it with a combination of an endocrine therapy, so that same sort of anti-estrogen or that hormonal therapy, and combining it with what we call active surveillance. And that's a combination of MRIs and mammograms for at minimum 6 months. Goal being, can we figure out if your DCIS, and sort of more broadly whose DCIS, is at higher risk for becoming invasive cancer, and if it's low risk, is it something we can continue to treat with just endocrine therapy and monitoring with active surveillance, and if it's deemed high risk, is it then therefore someone who goes to surgery for it to be removed? So it's 6 months of this treatment with, after that, the possibility of moving to surgery if it is deemed high risk, and continuing the endocrine therapy for up to 3 years if deemed low risk and someone we continue to monitor with the therapy.
Again, giving people options. You know, that you heard from Joe that it's safe to start with chemotherapy or systemic therapy for 6 months or maybe longer, for endocrine therapy for 6 months. If it's safe in the setting of stage 2 and 3 disease, for sure it's safe in the setting of people who don't even really have a cancer and don't have a cancer yet. We use the MRI as an opportunity to make sure they don't, right? So that is, and RECAST is actually an acronym. Reevaluating conditions for active surveillance that show it's suitable for treatment. I think that's right. Anyway,
Nailed
but
Well done.
just because you write it doesn't mean you remember it. Anyway, as we've discovered many times. I-SPY is also an acronym. Anyway, but as you've treated patients with this or offered this option to patients, is this something that's scary or is it something that's exciting, that gives people really an option with some security because you're looking for their individual response? What's your experience so far?
I think it is very exciting. I think patients have found it exciting. It's an opportunity to learn more about their specific DCIS and not just be treated as what we see in a textbook or what, you know, somebody else's DCIS might be like. I think with the appropriate sort of education and us coming to a conclusion as a provider and a patient together and making sure that we all understand exactly what the plan is has become very exciting, and so far has been a wonderful trial to be a part of, and patients are tolerating therapies very well and are really appreciating being able to take time to think about what's best for them, and not rushing into making any decision that they maybe aren't ready for or comfortable with.
Yeah. And I think it's an exciting way to bring in some of these new endocrine agents into the early stage setting. You know, one of the struggles we've had is that many of the endocrine agents women have found not to be so tolerable. And so this gives us a chance to test this in a way that maybe can move them into the treatment phase sooner. We're trying to put some pressure on the FDA to make sure that they understand that tolerability truly matters, especially in this long-term endocrine setting. All right, so Sandy, you know, you are the bottom line. Often what you say You know, I heard when I was in Israel, we were talking about some of these issues, and one of the pathologists said to me, deciding whether he called something ADH or DCIS, he said that depended on a core biopsy, depended on whether he wanted to see it come through as a specimen. Which
That's a good point.
is it? All right, so it felt very subjective to me. I'm like, really? Okay. So I mean, I think there is a lot of variability on how people call things. What's happening in pathology to help us get away from some of this arbitrary, or you'll see someone say like, okay, it's ADH. Okay, no, it's very severe ADH. Okay, but ADH, of course, is definitely not DCS, not cancer. You know, you don't have to take it out. You know, these are indicators for prevention, but I think sometimes the way people write things, whether it's a radiology report or a pathology report, actually can strike a lot of fear. And to the people reading it, I know you're not writing them for the patients, but they're the ones who are seeing it.
Am I on? We
Yeah.
are writing it for the patient. I look at every biopsy as my patient. And I know I'm the doctor you guys don't get to talk to, right? But that's
Except outside, all day today, you
well,
get to talk to them.
and,
Okay.
and hopefully some of you got to talk with my colleague Julia. It's not because we don't want to talk to you. It's because these guys keep us busy talking to us all day. But in seriousness, you know, what our job is to create the most accurate diagnostic category for each individual. And you've heard it throughout here. So even when you talk about Decision RT, which is a test based on immunohistochemistry that we perform on biopsies or on excision specimens, that test was developed here at UCSF by investigators in pathology. This is what pathologists do. We try and figure out with data who is going to respond to certain therapies, who doesn't need certain therapies because they have low risk. I think most of you in this room realize today that this word cancer, and by the way, we don't really, in pathology, use the word cancer. We use our own language. So we use carcinoma, but it's really the same thing. But carcinoma or cancer is defined as a malignant neoplasm. It's got that word malignant in it. And so for a long time, everybody thought cancer, black, not cancer or benign, white. It's a
yeah.
black and white, yes, no situation. But I think you guys all realize that's not the case. There's all sorts of shades of gray. And layered on top of those shades of gray are things that I can do to predict what is going to be the best therapy. What therapies are you as an individual going to respond to? And this is the term that people have been calling personalized medicine or precision medicine. And whenever my colleagues in biomedical research talk about precision medicine, I say, that's what we do in pathology. We're looking for evidence to give you more details about things that matter. And so some of those things are gene expression profiles. So the gene expression profiles that are used by Agendia to say mammaprint low were also developed by a pathologist here at UCSF, Laura Vantveer, before she came here when she was at the Netherlands Cancer Institute. And that became this very important test. I think that one of the things I'd like to do is remove that stigma of the word cancer from things that I see under the microscope that really don't deserve it because they aren't malignant. Or maybe they're just
They're
minimally
they're not
malignant.
on a path for killing the person if untreated.
Maybe, yeah, so they don't have that bad of a nature. Some of them are completely indolent, and we found them by mistake. But we need to have confidence on an individual basis when that's the case.
And actually, Jennifer Marti just sent me some papers yesterday. Thyroid cancer, always something that was taken out. A couple of studies just came out. Watch and wait for these low malignancy, probably non-issue where people have a 98% response rate. Leaving them alone, if you intervene later, you get the same outcome. This is like prostate cancer. There are, as Sandy and I know, we've been working on this for a long time, there are indolent cancers that we probably could leave alone or just simply excise. Those are the ones, I think, where we don't need to add on radiation and the various things. And we certainly don't want to treat the precursors of those things. aggressively. So I think that's our challenge, right?
Yeah, and I was going to say there's another level to this, which is the response to therapy. So if you have even a high-risk cancer, but you have a very high chance of having a complete pathologic response to your therapy, that's also a really good situation, right? One of the things I've said is we don't need breast cancer screening if we could cure everybody's breast cancer when we found it. It's obviously better to have screening and detect things earlier. It's easier to treat those things, but it's sort of a thought experiment. I was going to ask the surgeons, Rita and Laura. It's been fantastic.
And Jordan.
Oh, and Jordan. It's been fantastic that we've reduced the impact of doing axillary dissection. That's been fantastic. It's been fantastic that we've reduced the impact of giving every woman cytotoxic chemotherapy, no matter how low grade or ER positive her tumor is. Are we going to get to a place where we can be confident that we've had a complete pathologic response to the therapy that we give, maybe by MRI, maybe with a core needle biopsy, maybe with a blood-based DNA test, that we can avoid even doing surgery on those
Well, I
women?
would have a good answer to that. For I-SPY, the primary endpoint is proving that and being 100% sure of that, which gives us the opportunity, as Nicholas is working on, is to identify then which of those people, so Henry Cure and some people are working on that, but that gives us a chance to say, okay, of those people where we are certain, no ctDNA, no tumor, everything's gone, biology XYZ, who can we either do a focal radiation or no radiation? That's under development, right?
I want to make sure the surgeons talk because they're doing that hard decision of cutting or not cutting. But I just wanted to quickly say to that point, that trial I mentioned looking at HER2 positive with a complete response surgery and no radiation, there's a sister trial,
Yes,
which is
yeah.
if you achieve a complete response, forego the surgery and do radiation only. But then the next step is let's do nothing afterwards. So
Right.
slowly we're chipping away
And
towards
then I
that.
think, for the moment, later you could do core biopsies or various things that you could do, but also the surgery is quite small, and maybe you can, and there's been recently a paper showing that if you were node negative to begin with, you don't need even the nodes taken out if you have a PCR in the breast, and, I-SPY, we're predicting that. So that's, and we're working on making that better and better. So, right, so one last comment, and I'm asking one thing,
Well,
then get your questions ready.
I
We're
was
going
just
to turn
going
this
to
over to
say
you.
that we've talked this concept of ctDNA or circulating tumor DNA, which is DNA from the tumor that's found in a person's bloodstream. This has come up as a way that people are maybe deciding what kind of systemic therapy to give. But we recently looked at I-SPY data, and the amount of circulating tumor DNA, or if you can show that chemotherapy makes the circulating tumor DNA go away, you actually can predict how many positive lymph nodes a person might have when you go to the operating room. So I think that we are getting closer and closer to using things like ctDNA to guide how much surgery we need to do. And maybe we would need to do like a very tiny surgery to kind of prove to ourselves that it really is gone. But I think that we are approaching, someday in the future, we will not be doing surgery, I think.
I think some of these are tricky knowing how to use it. ctDNA may be the most helpful in determining who isn't getting a response and move on. Like, why expose somebody to toxic therapy that's not going to help them? But again, making sure we have confidence in it. That's, I think, within the next year or two, certainly it'll find its way into I-SPY, and then hopefully within a year or two into the general practice. Last question for you, then we're going to questions. Sandy, I know you're interested in artificial intelligence, meaning the ability to automate looking at these slides, and there's been a lot of things that say, well, we can actually, we can capture the information in a genomic test in all of the gene expression tests on a slide. Are we there yet?
We're definitely getting there. So the underlying concept here is that all the genes are doing is controlling the function of the cells of the tumor and the cells around the tumor. So if we grind that all up and look at the genes, we're really just doing a sort of peep through the keyhole at what is the functional capacity of that tumor. So when I look at a slide, I'm doing the same thing. I'm looking at the interaction of different cells, the tumor cells, and the tumor cells have lots of different variability themselves, but how are they interacting with the environment around them? But it gets to be a problem where my brain can't handle all that data, right? So there's all those cells and all those interactions, and so more and more we're learning to rely on computers to do analyses of complicated data, like visual data, that help us speed up the process of recognizing features that are important for predictive therapy response or for prognostics. And that's exactly what we were doing with the gene expression profile, peeping through the keyhole. So maybe we can do it, if we're smart enough, from the slides itself. That speeds things up. It reduces cost. There's a lot of benefit to that. The other thing I would say is speed things up is really important in the healthcare system. I mean, I'm sure all of you have encountered delays in scheduling, delays in treatment scheduling.
Require extra biopsies.
And so if I can have a situation where I can use AI to speed up the imaging read, and I can use AI to speed up the pathology read, we may be able to do sort of one-day service, if you will. We may be able to
Be
get to a
amazing.
point where you get a mammogram, the AI says this is an important one, the radiologist agrees, they do a biopsy, it goes immediately to the pathology AI who says this is an important one, it goes to the pathologist, and they say this patient needs to be treated and seen to be treated. We can do that all in one day, which today takes 3 to 6 weeks. So I think using the AI tools can be really powerful in both reducing costs and speeding up the process. And everybody I talk to is a little bit reticent to turn over all the decision making to the AI. But everybody I talk to is pretty comfortable with physicians learning to use these tools
To help.
to do things better.
Yeah, as assistants. Okay, I want to hear from all of you right here. Let's who are our rovers with the mics? Can I get our interns, our fabulous interns, to come around and rove mics? Go ahead and Sandy, just get your question right here. Annabelle and yeah. So we'll
I
take
would
one from
like
over
to
here.
know
Yeah.
about the laboral carcinoma in situ. What about
Lobular
laboral
carcinoma in situ,
carcinoma in
LCIS.
situ?
So the question is about lobular carcinoma in situ, or LCIS. So this is similar to DCIS, meaning that there are these cells that look like carcinoma cells, but they are not invasive cancer. They're contained within the structure that is the glands of the breast, which consist of ducts and lobules. The difference between LCIS and DCIS is that LCIS usually does not become invasive cancer in that same spot. However, people who have LCIS, they do have high risk of forming breast cancer in the future in either breast. So when we find LCIS, it means we know that that person has higher risk than the average woman of developing breast cancer.
And in fact, that's exactly what we worry about with ductal carcinoma in situ. There are some, the minority, maybe 30%, that really are focal and probably are good surgical candidates. The rest are actually more like LCIS. And how LCIS got called not cancer and a risk factor, and DCIS got called invasive cancer, who's responsible for that?
The
But- and I think-
pathologist.
Yeah, well, I was
No,
gonna
it was
say,
Hagenson. It was
Some-
Hagenson.
Something that is important
Surgeon.
to know, though, is that sometimes when the biopsy is a very small biopsy, like just done with a needle, we have to remember that we're only giving the pathologist a very, very tiny fragment of material to look at. So there are individual situations where we say, well, I'm not sure if the pathologist is telling me that the exact correct answer here, and do we need to give them more material? So maybe Sandy, you can comment on that.
Yeah, so a couple comments on that. The first one I want to make is you know, we talked about carcinoma being, or cancer being, all the shades of gray, including white. Well, so lobular carcinoma falls definitely in that category. I do not think it deserves the name carcinoma.
We don't think GCIS deserves the name
Much
carcinoma,
of the DCIS also, but if we just talk about lobular, what we know, as Rita just articulated, is it's a risk factor, it's a risk marker, and it's an important one. But we don't think it progresses to invasive cancer. So if the thing that I see under the microscope does not have malignant intent, we can't call it a malignant neoplasm. So there has been an effort by some in pathology to change the name and call it lobular intraepithelial neoplasia rather than LCIS, so that we don't scare people unnecessarily with this carcinoma term that we throw in there. It's kind of a biological description that doesn't meet our objectives for clinical treatment.
I think one other thing we can say is that MRI is also a useful way of looking at the whole breast. And we just have to get away from the idea that everything that lights up on an MRI requires a biopsy, because it doesn't. And as we start to use MRI better, we can use it at its highest function, which is there an obvious cancer there? Is there something obviously we should biopsy? Is there a big globular cancer there? Is there something else? But if we can have a little self-control and not stick a needle in everything, we start to understand, oh, some of that's just a little bit of background enhancement, here's the pattern, whatever. That's, I think, one of the major contributions that
Yeah,
well, AI will help with it, but also recast will help with it, because we are following, we're making a commitment to follow, and most of that goes away with endocrine therapy, actually. So anyway,
Yeah,
I want to make sure that we get
What you're
the
hearing
2
Laura say,
seconds.
I was going to comment, was my second comment, which is
2 seconds here, because we got time
no,
for
no
like-
lab test should be taken by itself. It needs to be put in context. And so if I call it LCIS and Rita's concerned that that's the tip of some sort of iceberg, I didn't get a good sample, that's in context with the
Correct.
MRI. We
That's
have to put
important.
it all together.
Exactly. Okay, other questions? Go ahead. And then there's someone get a mic up there.
yeah.
Go ahead.
Hi, everyone. Thank you so much for that beautiful discussion. My question is kind of two-part. One is for trainees and one is for like the audience and everyone who wants to understand. You talked about amazing technologies coming through, like, you know, Decision RT and ctDNA. What sort of new frontiers should trainees focus on, like early on? Like, what should they be working towards? What are the treatments that you think are going to be the next,
question.
you know, next generation kind of treatments? And then what kind of discussions should patients have with their surgeons, sort of like not like patients who are not have access to UCSF, but other places who are not, you know, like thinking about these things, but what sort of discussions should they have for the next frontiers of those treatments?
All right,
And
perfect lightning round. So Joe, what, quick answer, we're going to ask each of our panelists. So the question is, in this new world, what should trainees be thinking about as they're trying to pick their field, and how should they focus their training, and what are things that patients should be asking of their physicians?
I think it's clear we are in the information age, right? Like we are generating so much data, and there are so many companies going after the same markets and, you know, profiling the tumor and then the blood. And I think understanding how to use the data and understanding the biology and the biomarkers and tailoring the treatment for that and when. If I just use ctDNA as an example, personally, I think it's coming. It's not necessarily here yet in all scenarios, but the assays are not sensitive enough. When we see an increase, how much of an increase warrants actual treatment? And you can't have those discussions without also having a discussion about the toxicity that comes with those interventions and doing those interventions sooner than you otherwise would. So it's a lot of
Learning.
it's a lot of learning, it's a lot of prioritization and having balanced discussions, and those will be individual to the patient. And so for a trainee, I would say it's so important to learn that there's no right answer for everybody. I think that's something you learn over time. and standards of care. That yes, there are guidelines and standards of care, but for the patient in front of you, it depends on what their goals and priorities are to get to the right treatment.
Rita.
I think that for trainees, it's always important to look at what are the problems that patients are facing and trying to tackle those problems. I think one really big problem is, if we knew who was at risk for developing breast cancer and we could prevent it, then a lot of these discussions that we're having would be irrelevant. So prevention is a lot better than trying to treat once the cancer has already formed. So I think better prediction of who needs screening, what kind of screening, and what can we do to stop the cancer from forming is a huge unmet need. And then for patients, I think asking your physician about clinical trials, I think is important.
My honest answer for trainees is whatever they're excited about. If you're wanting to show up and hours fly by because you're in that class or that lab, that's better than shoehorning something. So that's now in radiation, if I had to pick something, I would say flash radiation. That's radiation delivered extremely quickly. It has some interesting properties where maybe side effect profile is lower, but
Oh, I love that. Should we start that tomorrow?
if I wish we could, not there yet. It's a research topic. And
Love
then
that.
for patients, I want to echo again, clinical trials, clinical trials, clinical trials. That's the best way to have a huge impact beyond one's own care.
Trainees, be curious. I will say you, AI is not the solution. It's a complement. AI cannot replace imagination. Michael, what is the term? Where is he? It was asymmetric or something data asymmetry. So really thinking about, that AI would, if you had someone who looks at the data, say from the area of Galileo or when the Wright brothers were trying to fly, AI would not have said that the Earth was not the center of the universe, and it wouldn't have said that the Wright brothers could fly. You have to be able to look at things differently and have imagination and find new answers. So it will not replace us and imagination. Be curious. I would say for patients, to get your data, take your time, ask questions, what's best for me? And for the whole field, AI or data cannot solve the problem if we do not demand that we collect data in a uniform, relatively uniform way, a minimum set of data, and make sure we collect the outcomes. If we don't get that data, we are doomed to speculation. But if we get that data, we can learn from every person in practice as well as trials. So make trials look more like care and care look more like trials.
Oh,
I don't have a ton to add to all of those thoughts, but just to echo clinical trials, I think for both trainees and patients to understand where the boundaries are being pushed and where people are thinking about things and trying to change things. Really, every standard of care has become that because of a clinical trial. So sort of, you already asked me this, but even if it may seem scary at the time because it's a clinical trial, it most likely will eventually end up being what becomes the standard of care. And being able to be on that front line, either from a trainee perspective or a patient, and learn about it and be treated in a way that will become the future is both more exciting, if you can reframe it to think that way, and less scary.
clinical trials are tomorrow's treatments today.
I was just going to, these guys kind of said this, but 2 words, think different. And one of the ways I think different is I think of myself as still being a trainee. And I'm always trying to explore the combination. And I will say there's a combination of 2 things. Technologies, broadly speaking, and those are advancing super fast. So being interested and curious about them, understanding what they can and can't do, but in the context of, somebody said, the problem. What is the problem? So you can go all in on technology, but if you're not trying to address a problem, it's not really going to go anywhere. So if you just keep those 2 things in mind, what's this cool technology? And then maybe what's the problem I could apply it to? I think you're in good shape.
All right, I think that is a fantastic, okay, one last question, and then we're going to end, so you have time to enjoy all the posters and...
In terms of the importance of clinical studies leading to new standards of care, I'm wondering what intentional practices come in UCSF's clinical trials, some of the specification about what's being done now was to people 65 and older or postmenopausal. So what built-in intentional practices are for capturing, including patients that are being diagnosed at younger ages?
Oh, that's easy. Again, we can, go ahead, Joe.
I would say most trials are, in terms of age, are being
Open to everyone,
open to everybody.
including men with breast
In
cancer,
fact,
by the
when
way.
we review trials through our scientific review committees and the IRB, it specifically asks, like, is there a reason you have not included everybody? And we include men in our breast cancer trials, and that, I would say, yeah, it was a relatively new thing over the last decade, previously less so. So I think there's been a huge push to be more inclusive. Now, I will say on the flip side, in terms of biology, the way trials are being designed they're more specific. And so the eligibility criteria can be more stringent. And so it's really important to check with us or other institutions where there are trials at every step along the way, because if you've had one too many endocrine therapies or one chemotherapy, that can exclude you from a number of clinical trials. So you need specific mutations. You need to have this treatment and not that treatment. So it is more stringent in order to have more specific trials you need fewer patients to see results. And I think that's a good thing. But in terms of demographics and age, that has been broadened.
Any other comments? I think the one thing that we also try and do on these platform trials is really have as broad an eligibility as possible. Broad, like iSpice open to women 18 to whatever, right? So and that we really try and figure out how you can treat each type of cancer, and you let the data teach you. Recast is open to 18 to any age. It's basically any age that you have DCIS. And so we are not trying to preclude it. We're not including hormone negative patients because we're specifically looking at that particular biology. We're looking for something else for hormone negative. Don't worry, we'll find that. But it is, we are very focused on trying to let the data teach us and find options, let the options that we're testing figure out who benefits from what.
And we all need to be, as patients, as advocates, as physicians, turning to our public representatives to make sure that we're supported on all levels, so that these types of trials and efforts and funding and resources can continue to exist and grow, actually.
Rita?
Yeah, and then just to address a comment about like postmenopausal versus premenopausal. So I talked about with like omission of sentinel node surgery. So the two trials that were done looking at the safety that actually included both premenopausal and postmenopausal women. It's just that when the guidelines have come out about who to apply the findings to, there's always more concern about doing less, rightly or wrongly, in premenopausal women with breast cancer. And so the guidelines have actually been a little bit more specific about, well, if it's a little bit risky, we're going to only do it in women who maybe don't have like 50 years in front of them to maybe have a recurrence. But all women were included from the age of 18 in those trials.
And I will say, one of the most important things that all of you can do is you can advocate for making sure that we develop good early endpoints in the course of these new trials that can be used by regulators for accelerated approval. So to be able to bring the new, less toxic or the endocrine therapies that are more easily tolerated up front and getting an approval so we can provide treatments that are better that people will stay on. And iSpy or some of these other cancers to be able to say, yes, this is an early endpoint that I'm willing to give temporary approval to and let the data learn. That's true for DCIS. If we want to speed up the time that we're learning, the public must understand and be educated that robust early endpoints that we can measure in the course of care, can predict what's going to happen 3 and 5 years later, that is absolutely essential. That will drive progress. And we have to be clear about it. We have to advocate for it. This is really, if you think about the AIDS movement, they advocated for this kind of research, and that changed the field, and it sped up the time in which they were able to get life-saving treatments by a decade. or more. So if you can do that, and if you have any questions and want to talk about that, let us know, because that's really, really important. That isn't exactly the case I'm going to make Tuesday to the FDA, when our merry band of team is going to go argue for that. Okay, so anyway, we're going to give you a break. You get a half an hour out to, and can I have all the interns stand up and all the posters? First of all, and Francesca, can I have everybody stand up? I know there are more of you. Stand, stand, stand. Okay, there they are. And I want to thank everybody. As I said, this is not all of what's going on in the Breast Care Center, but it gives you a taste of the kinds of things you're doing. Don't hesitate to go up to them, ask them questions. We'll all be walking around to be able to answer those questions. Next up is going to be Kim Badal's talk. We'll start a little bit like at 12:25. Then after that, your chefs for the day are myself and Dan Dornbush. Dan, raise your hand. We have I forgot the aprons, but anyway, you'll see us in a moment, teaching healthy, fun, delicious ways to make salad. Okay, so and then we have our salsa break. Everyone's got to get up and move. We'll have a special exercise, which also includes moving some of the tables. And then we have our final panel, really talking about hormone replacement and breast cancer, so which is a hot topic. We'll talk about that at Rise Up as well, but that will be a lot of fun. Thanks the panelists for a fantastic discussion. Okay, break. Everybody go out and explore all the great things outside. I might send Michael home. I have to decide, is it really worth it? I mean, that's sort of ridiculous, but that's okay.